this week on the BackTable podcast.
That's what you're shooting for. If you can improve an ECOG status, that's like almost as valuable as improving a pain score, right? I mean,
absolutely,
because your ECOG status may now make you eligible for other therapies. Generally, nobody's going to leave the procedure being worse, right? Out of the peri-procedural part, if you come in for a prophylactic fixation, you're going to be sore for a week or two. You're going to know we were there. If you come in and you're 10 out of 10 pain, the pain from the procedure and the ablation is going to be less than your normal pain. You're probably going to feel better the next day. And we're going to get you up and moving around. And so it kind of goes depending on what you're actually going for, right? I mean, if it's a prophylactic fixation, it'll be a little bit different than if it's, for pain. Unless you have a nerve complication or you create a complication during the procedure, we really don't have anybody that gets worse from the procedure, right? That's very few and far between.
Welcome, everybody, to the BackTable MSK show. I'm Kavi Krishnasamy. I'm an interventional radiologist, interventional oncologist at UAB in Birmingham, Alabama. I have an amazing guest with me today, Dr. Brandon Key, interventional radiologist at MCW in Milwaukee. Brandon, take it away. Tell us a little bit about yourself.
Hey, Kavi. Yeah, great. Thanks for having me. Really appreciate it. Yeah, so I do interventional radiology at the Medical College of Wisconsin. I specialize mainly in bone and MSK intervention. We do anything from palliative nerve blocks, neurolysis, all the way to pelvic fixation. Really cool practice. Really lucky to be in the field that I've been able to be in and train with the people that I've trained with. I was lucky enough during residency to work with Steve Yevich in the early days of when he started doing this at MD Anderson. Then came to MCW and worked with Sean Tutton, who's been my mentor. We keep in touch. He really helps with cases. And those two really pioneered a lot of the stuff that we're going to talk about today. I'm coming in on kind of the back end of them, having refined a lot of processes. So we're really able to kind of push the limits now more so than we could a decade. It's pretty awesome.
It's really amazing. And our topic for today is specifically bone intervention, bone stabilization, right? In the pathologic, non-pathologic realm. I think the practice that you have and the individuals that you have worked closely with really lead kind of the world in bony interventions, especially in this space. And it's an area that I don't think is really taken off in the US yet for a variety of reasons. Do you mind speaking to that? What's your sense of kind of implementation of bony fixation into IR practices around the country, and what are the barriers?
I don't think there's a lot of training programs that actually are training at this right now, right? I mean, a lot of interventional radiology programs out there still aren't even offering vertebral augmentation, vertebroplasty. Getting over those training barriers, I think, is what's challenging, one. And I think with these podcasts like this, any of the lectures you can go to, the MSK master classes that we've put on over the years, I'll try to help get that out. So just getting the training's tough. I think everybody has the skill set to do it. We're all comfortable with ablation. Most of us have done CT guided cases. We're, done some needle guidance. Getting over the inertia of getting started with fixation, osteoplasty, it's a different skill set than angiography. And so you have to become comfortable with it. You have to do cases. So I think that initial exposure is a little bit hindering in some instances when people want to get started. The other one is once you get started, you just got to have to work with everything that you have. One thing that I was told actually by Steve Yevich when I went to MCW was, whenever I started working with Sean, was, Sean knows his equipment better than anybody. Learn from him how to use it and how to leverage it. And he really did. I know I can run most of the entire room whenever we're doing these cases, from setting up the cone beam. I run all the needle guidance segmentation software. And unless you're doing those things, these cases can be challenging and hard, and it's going to be a barrier. I think another thing that we don't look at or give enough appreciation for is the actual setup of the patient and the prep. If it takes you 10 minutes to get a spin and you're trying to do 5 or 6 spins during these cases, you're going to have hour plus in just trying to get your imaging set up. If you're unsure how to run the machines, it's just going to be frustrating. The frustration will result in you not doing these cases right. And you have orthopedic colleagues that scrub in, and all of a sudden now they're there for 4 hours while we're just trying to do spins and get one needle access. So all those kind of things come together. The great part is all the new technology we have now is just making this procedure easier and easier. The image guidance softwares are getting better. The tool sets are getting better. We're starting to get vendors that are actually developing some tool sets to do these. And all that combined, it's going to make it easier for people to start doing these procedures. I think the other thing is there's actually been a push towards multidisciplinary and collaborative care in the last decade, right? I mean, I think that's the big push in most places. So a lot of these barriers are coming down. They still exist in a lot of institutions, but I think people are opening up more and more. My orthopedic surgeon colleagues here at MCW are awesome, extremely collaborative. So it makes it a lot easier for me. But what I do see from them is there's a huge interest in these procedures at national meetings. There's large segments at AAOS, MSTS, all their conferences that they're going for oncologic work that have segments dedicated to palliative fixation and ablation, which is great because you're getting the interest and appraisal from the orthopedic side. So there is instances where we've had orthopedic surgeons who are reaching out, wanting an IR to collaborate and maybe not finding one that's ready to do this or to take that delve or that's been trained in it. So there will be at a certain point, hopefully in the near future, where all of these kind of align. We're going to have IRs in multiple institutions that want to do these, orthopedic oncologists that have seen it on their side and see it be validated to where they can then come and, start collaborating.
You make a lot of really wonderful points. I will point out, I think MSTS is actually this week in Mexico as well, right? So if I'm not mistaken, I think a great opportunity to branch outside the IR space and go to a little bit more of a multidisciplinary conference, right? But your points are very valid. I think for me, I really, preach is the wrong word, but I really teach this to my fellows, the importance of having a seat at the table and being involved in the multidisciplinary team, whether it's lung, whether it's kidney, whether it's liver. My whole practice is cancer and pain, and then the intersection between the two is cancer pain, right? And so my fellows like to joke with me that when I'm in the liver doing a complicated, multi-dose Y90, there's like 8 spins that happen. And, at this point, my team is just a well-oiled machine and we can just knock out spins in seconds as opposed to tens of minutes, as you said. So there's a lot that goes into this, but it still boils down to that multidisciplinary care. And if you're not going to the multidisciplinary team meetings, the tumor boards, the clinics, if you have them, it's hard to advocate for a practice, understanding though completely that this is a collaborative space. And just like you, my orthopedic colleagues are actually wonderful, right? And so that makes the collaboration in this space, having the one-on-one and group conversations much, much, much easier. So very, very, very well said. Why don't we get into it? So a lot of bone in your practice, as you said. What are you treating and stabilizing from a pathologic fracture standpoint? What bones, I guess?
Yeah, the majority of the stabilization is work within the pelvis, right? We're looking at acetabular fractures. To try to make it in its most simplistic form in the pelvis, we're looking at columns, right? Anterior column, posterior column, and then the supraacetabular region. We call it a P to A corridor. It's essentially the posterior superior iliac spine to anterior inferior iliac spine. That kind of ties both columns together. Most of the literature you'll see is reestablishment of that column support, right? And actually what we're looking at now and what we're seeing more and more, and especially with the new device, IlluminOss, is that column support is now translating into them being able to do a traditional hip arthroplasty later on, right? We're eliminating the need for all these extensive cup cage constructs with cement and pins going everywhere. And now we can reinforce the columns that they need to then do a total hip into. So it's changing the paradigm a little bit. And there's actually been some recent podcasts, actually our webinar that was done from some orthopedic surgeons at UT Houston, which is a huge orthopedic place, where they were discussing this very thing, where they're using IlluminOss to then kind of come back in and do total hips afterwards. So everything's kind of evolving there. Other fixation sites, will we put screws in different places to help hold constructs together? Yes. I mean, we've done sternum, glenoid. You can do it in the proximal femur for femoral neck, impending femoral neck fractures. There's a little bit different those constructs there than you would see traditionally in the pelvis. Usually outside of the pelvis, it's more osteoplasty, and you're really not going to get back to biomechanics like you can in the pelvis. Long bones, proximal humerus, proximal femur, those are completely different beasts. There's been a lot of attempts at trying to do percutaneous type fixations. Most of those have failed, right? The forces that are on those bones are drastically different than, say, an axial loading force in the spine or some of the forces that we'll see in the pelvis. And so those are more, to me, temporizing measures. Again, IlluminOss is kind of changing the paradigm a little bit, which we can discuss a little bit more later on those regions. But I think the two main corridor things that you're going to think about for fixation are going to be pelvis and sacrum.
And sacrum. Okay, got it. Well, I'm glad you brought up IlluminOss. We'll talk about it later is I don't want to spoil the fun, if you will, but unbeknownst to me, there is a tremendous amount of literature for IlluminOss going back 10 plus years now, including in long bones, actually, in humeral and femoral and fibular and metacarpal fractures. And so just a fascinating space. I'd love to dive into that. We'll save that for a little bit later in the episode. What about, so in your practice, obviously pelvis, you said spine, a little bit less in terms of long bones. What about things like rib fractures? I know that's way out in left field a little bit. Is that a thing today? Is that a thing that we may see in the future?
That's interesting. I don't know. It's not something we really go after. Honestly, if I've got somebody with a pathologic rib fracture, we're typically just going to do a cryoneurolysis, try to help them with pain there, or just ablate the lesion. It would be interesting. I don't know from a fixation standpoint, how to pull that off exactly right now, and if anybody's attempted to try. Ribs are a challenging place even to biopsy, right? And so I think that would be a possibility because those are painful. Having had a couple myself and random other things, I know how much that hurts.
Sure.
And so that's a big point of pain for patients. And so it would be nice if we could provide something more than just say denervation.
Yeah, great point. So, okay, well, we'll see, I guess, right? Well, that covers kind of pathologic fractures. What about traumatic fractures or non-pathologic fractures? Is there a role in IR practices for fixation in spine, non-spine? What do you think?
Yeah, definitely. My the orthopedic guys here, and typically the new orthopedic surgeons are well-versed in trauma, that have done fellowships and high-level trauma programs. They're great at perc fixation, right? That's like what the forefront of, a lot of the orthopedic trauma is percutaneous pelvic fixation, right? And so those guys are great at doing it with the C-arm and the OR. I have had our trauma guys here from time to time come and be like, hey, we can't see real well in the OR. This patient's really big, or there's already hardware in place. Can you get a screw through the S1, S2 corridors, even though this patient already has a lumbosacral fixation? And, so those are the times where they've come to me to kind of get some help on some of those cases. I think, again, bringing up IlluminOss a little bit earlier, or like we talked about it, you bring in a new device that is indicated for trauma now, right? Like all of a sudden that fragility fracture of the proximal humerus or distal radius can be treated by an IR if you want to go in. It's a percutaneous fixation device that's on label for that. So you can start adding it into these areas where it wouldn't be out of the question that if somebody was a non-surgical candidate for a traditional fixation or rod or plate that you wanted to temporize with an IlluminOss in the proximal humerus as an IR, totally within your realm. And in fact, even if that person does fracture down the road, having that IlluminOss in the space, in the intramedullary space, actually allows for more traditional plating to occur, right? You can drill into these devices. We do a lot of combination screw IlluminOss cases, and we're really leveraging the fact that you can drill through and screw into it.
That's super cool. I want to save a little bit of that because I love to understand your treatment algorithm for when you're screwing into an IlluminOss device versus not. But I want to just take a moment and better define some of the tools that are at the non-IlluminOss tools that are at our disposal at the moment, right? So screws, that's one conversation by itself, and the different types of screws. Can you give us a quick primer on what types of screws you're using?
Yeah, sure. I think I'll even take one step back further from that. I think at the base of every case, we start off with standard bone cannulas. I use an 8 gauge. I use the 8 gauge striker one because it's non-tapered. Most of the other 8 gauge cannulas that are out there taper down. And the reason is I want to be able to fit my K-wires through it. So whether or not I'm going to pull a striker 3.2 guide pin or an osteocentric 2.8, I want to be able to have one device that goes in that I can feed all the different size K-wires I may need. They also accommodate all the ablation probes too, right?
Okay,
so
got it.
We start every case with an 8 gauge cannula. It's easy for us to work with. It fits under the II. It fits in the gantry of a CT if you have patients coming out versus having this long K-wire sticking out, right?
Sure.
It's also a very common device. If you do vertebroplasty, you're used to handling these cannulas, right? So we start with the cannula, and then your typical ortho set is going to be an orthopedic trauma set. Caveats are not all orthopedic trauma sets have the length of screws you may need to do some of the cases. When you're spanning transiliac, transsacral, you need long screws that aren't typically in those sets. Some vendors have really good sets now that have all of that. And from a basic perspective, from those sets, you're going to need a power set, which is basically a power drill and battery. And there's 2 connections there that will give you a cannulated driver that you'll use to basically take your drill bits and the driver for the screws over a K-wire. and a hand driver. If you had those, you can pretty much get anything done. A lot of the other tools in those sets are problem-solving sets for larger orthopedic interventions or open interventions. So they're not really necessary, sometimes helpful, but not needed. Screw-wise, I think you really only need to know 3 screws here. There's a fully threaded screw, which obviously has threads all the way down the length of the screw. You have partially threaded screws of 2 varieties. They have threads just at the distal end, and some have threads almost 2/3 the way up. What would you use those for in different instances? I think the ideal goal is you use as many threads as possible. So if you can fit a fully threaded screw in there, great, go with that. If you have a fracture line you're trying to reduce, you're going to use one of the partially threaded because it acts kind of like a lag bolt in construction. The distal threads grab, the proximal part head of the screw is going to compress that fracture down. We also use partially threaded screws if we think that we're super close to the acetabulum or neuroforamen, and we don't want threads sticking out into or threads sticking into the subchondral bone and or into a neuroforamen, right? So let's just say your corridor is super tight. You don't want those threads sticking out causing any sort of irritation or issue there in the joint. Then we just put a partially threaded screw across there. No big deal. There are fenestrated screws that are out there now that it's one more tool in the toolbox that allows for really targeted cementation and pretty tough areas, right? So ways to get your cement in when you do this, you can cement through the end of your screw.
Okay.
Sometimes that requires you to lose K-wire access, can get really dicey if then your screw deviates, say if you're in a big lytic defect, so not recommended. Can be done, but don't recommend. So you have to have a lot of additional cannula placements, right? If you want to really cement along your screw, which I would recommend that you do. These can back out. You're not in great bone. This is one of the reasons that this procedure took off in IR is because we would ablate, cement, and screw all in one setting. And so in looking at that, I mean, these new fenestrated screws that are out are also just one more tool in the toolbox.
Got it. Who makes them, by the way?
FlowFX. It's great.
FlowFX.
It's awesome. They have this like proprietary way that the system docks to the screw head, and then you can isolate individual fenestrations. So you can go and say, I only want cement to come out of the end of this screw until we got it really seated. And then as I back up across my lytic defect, say in the sacrum, okay, these fenestrations are right near the nerve. I'm going to hit it a little bit, but then I'm going to pull back a little further and get the fenestrations away from there. So that way you're not limited. Yeah. So if you start seeing cement leak in a fenestration, you're not like, out into the neural frame, and you're not like, I'm done here. I can't, risk putting any more. No, you just back up and isolate a different fenestration. So they're really great. We use them in the sacrum a lot. Intermittently, we'll use them in the pelvis as well, depending on kind of the lesion we're looking at. But another awesome new technology that is, within the last few years.
That's fantastic. And just to your point that you made earlier, understanding the devices in the space, just paramount to success, right? And what can be used where. And there is always going to be evolution. We have to embrace and encompass that, right? So great point. Let's switch gears a little bit. Let's talk about patient prep. You're doing this in IR, you're doing this in the OR, doing this in CT. Where are you typically doing your pelvic or bony cases?
Yeah, so I try to use cone beam CT and needle guidance as much as I can. I think once you develop a comfort with it, develop a comfort with the views, the pelvis can be a little bit disorienting at first, but I think the cone beam CTs during the cases with your device and kind of help with the comfort level there. One exception, I do almost all my sacral cases with CT. It's really hard to get a good lateral to put screws through the sacrum from a transiliac transacral approach. There's high rates in orthopedic literature of nerve root injury doing transiliac transacral, which I think is we all know to be the best fixation, right? I mean, if your sacrum's diseased bone, you don't want to be anchoring screws into the middle of the sacrum when it's heavily diseased, right? So you want to span across and grab as many cortices as you can. That being said, again, you got to really do S1, S2 corridors if you have a complex fracture. Otherwise, you can get some anterior rotation of the sacrum. So 2 screws through there is almost a necessity. And so what we found is that S2 corridor is super tight, hard to see on a lateral, especially in a large patient. And so we reverted to just basically doing CT for those cases. And you can do all these devices in CT because we use IlluminOss in the sacrum, we use FlowFX, and we use our standard screws there.
Got it. That's okay. And then are these collaborative cases for you with orthopedics, or are you doing some by yourself, some in collaboration, or generally just all by yourself?
Yeah, so about 95% of these cases are done with both orthopedic surgery and myself. There's a few cases from time to time that, for rush of scheduling or for scheduling issues that we end up, doing them on our own. But it's solely just the way we have it set up, and it's great to have them there.
Yeah, sure.
You learn a ton, right? Both sides get to learn a lot. They're just fun to work with too. Our guys are great. There are places I know that a lot of these people, you're doing them independently, right? Like you may have an orthopedic oncologist that you kind of work with that says, I think this patient should have this done. Let me know if there are any issues after, kind of thing. So you don't have that collaboration, which can make it challenging to start learning all these devices, right? Like who do you turn to like, how does this power set work? How do these tools work? Like, you're relying on reps a lot at that point. Some of them knowledgeable, some of them, not as helpful in some of these cases, because you may have a trauma rep there and you're doing a malignancy case, right?
Yeah, great point. And, I with all our devices, all my complex cases, I tend to have reps there, and my reps for the different specific devices are fantastic, no question about it. But I think there is a important role to understanding kind of the scope of what the procedure is going to be and the devices that you're going to utilize without having to rely on somebody else to kind of give you that information in real time, right? So I hear you completely. Okay, so either or positioning. Let's focus on pelvis specifically. Positioning, supine, prone, decubitus. Does it depend on the case? How do you decide?
I would probably say about 90% prone. From a prone approach, I can get any corridor I want in the pelvis easily. There's no patient moving. There's no, worrying about, what we have to go through to get there. From prone approach, I can do what we call the standard tripod fixation in the pelvis. We can really and we can do the sacrum that way too, right? What I think is often overlooked when people start looking at these cases is the prep part. It's super important to your success in the case and being able to access the angles you need to put your K-wires in or the trajectories you're going to get. So we have a very, like Sean Tutton, whenever he was here, and William Lee, who was working with him at the time, they had this whole book that's laminated in the IR platform that we have that is a guide to prep for this case. That's how important it was, right? They called it the Screw and Glue Survival Guide. And that's been dispersed amongst, most of our fellows, people that have questions about prep. I just send them a copy. What we do is patient goes on the table, they get 2 big chest rolls, which is basically a blanket, warm blankets, rolled up, taped. 2 of those go under the chest. 1 of those goes under the pelvis, across the pelvis. All this does is this elevates the patient up off the table so that the arms can be tucked to the side, right? You got to be able to spin. So patients have to be as lean as possible. The other thing it does is it elevates the pelvis up off the table so that you can get any angles that you may need, right? So once the patient's elevated up off the table, actually before they go down, we put a sheet across the 2 chest rolls that drapes down. That sheet actually then gets twisted and tied up around the patient's shoulders. So just imagine it going around the side. Arms are tucked. That sheet goes there.
Also keeping the arms in.
And then it ties. So that sheet is what's going to hold the arms in. That sheet is going to hold them to the table. We put a blue strap over that sheet. We put a wide blue strap over the leg. So literally from the mid-back to the mid-thigh, there's nothing impeding me from getting to the patient, right?
And just to reiterate, and I know this is not always easy in every patient, but you're not supermanning any of the patients.
No, we don't. With this prep, we've had no issues with patient size. We've not had to do anything like that. The only way that we venture off and we'll do something outside of that prep is if, say, the patient's shoulder can't, for whatever reason, they have a concurrent injury. But this is the prep that we do for every sacrum and pelvis that we do. Similar prep for what I do for all my vertebroplasties too. It keeps the arms out of the way. It allows me better access and visualization on a lateral for spine. So it's a pretty standard prep for us. It's also geared to make cone beam CT easier. And so after all this is done, the techs will do like a test spin. If we can't easily spin, we have to make adjustments until we can easily spin. There's an anticipation that we're going to spin anywhere from 2 to 6 times during a case, right? I can't have it take 10 minutes every time we need to spin. After that, they're prepped, and we use an IO band over the field.
Okay, got it. It's interesting that you brought up vertebroplasty, kyphoplasty. I don't find myself, I don't know that I've ever done a cone beam in that setting, so I still tend to put the arms up, and maybe I shouldn't, but I love the idea. I absolutely put rolls under the patient to kind of help lift them up and better visualize the spine. So that's a great point from just an ability to spin standpoint. You talked about guidance software. I don't know if you have Philips or Siemens. Obviously, both have needle guidance software. Is there anything else that you're using?
No, I think that's it. And I think to kind of talk about the needle guidance part a little bit, this is software too that, if the first time you're really using it or delving into it is going to be one of these big cases, you're going to have struggles, right? And so I think, really understanding needle guidance software, the nuances of it, the limitations of it come with other cases. And, that all comes to fruition when you take on these bigger cases. So, if it's just a small lesion that I know I'm going to go under fluoroscopy that you can pretty much see, and I'm just going to do an osteoplasty or a quick ablation that really doesn't require needle guidance, I'm still going to spin. We're going to segment out the tumor. I'm going to make sure that I get exactly where I need to be with my probes. But all this is like preparation for those bigger cases, right? It helps you learn how to push the limits of the different styles of what you're going to do. We segment out all the tumors like roughly with we call them polylines. It's in the Siemens ecosystem. But that just these little visual cues that you add to the screen help you with cementation, right? Like, is that still in the lesion? Is it not? Well, I got this little reference line right there. So there's a lot of little tips and tricks that I picked up from Sean, my time working with him, that we implement that just make your life a lot easier. And so that all comes with just understanding the software.
Yeah, and it's all great points. You have Philips or Siemens or GE, I guess, for that matter, or Canon.
I'm all Siemens.
Siemens,
I haven't really messed with any of the other ones.
So I'm a Philips shop, and so I love the idea of kind of segmenting tumors and having everything kind of overlaid on your fluoro image. The challenge that I face is how do you get to your bird's eye view or your progress view? And like sometimes the eye can just not get there, right? And especially I think with odd angles in the pelvis, I assume you are seeing some of the same. So what are your workarounds in those types of settings? I know that's not an easy question to kind of field on the fly. I apologize, but what are your kind of workarounds there?
Oh man, that is like one of the number one questions that I get and that gets asked after people start to get into this. So you're barely ever going to get a bullseye view. There's only one corridor in the pelvis that you might get it. That's that posterior to anterior, that posterior to superior iliac spine to anterior inferior iliac spine corridor. That's about it. All the other ones, we use different triangulation methods. Again, all credit to Sean Tutton here. So what we do is we get our guidance line projected on the screen, right? So you've drawn it out and you take a K-wire and you position on the outside of the patient in line with your guidance line.
The progress view, basically, right?
Well, any view. So you just have your guidance line displayed, right? So then you take a K-wire on the outside of the patient and line it up with your guidance line. You make a mark on the patient. So you draw the length of that line. You then go into a progression view or any other obliquity and you do the exact same thing. Line up your K-wire on the outside of the patient with your guidance line on the screen. Draw that on the patient. Those two lines will converge. Where they converge, that's your skin entry point. The other little tidbit that has made this a lot easier is that when we're setting up the case and drawing our lines, where our cone beam, our needle guidance line enters the bone, we put a little crosshair marker. That marker serves as not only a visual, but also a visual and tactile marker, right? So as soon as the tip of your needle gets to that point on the line, if you're not contacting bone, you're out of plane. So we've triangulated our skin entry point, and now we're triangulating our bone entry point, and you're doing it not only with visual cues, but tactile, right? Because you can be way down your line, and all of a sudden you go in a different plane, and you're, way anterior or posterior to the bone, right?
Sure.
So having having that little line there, it takes out the guesswork, right? If I'm in a single view, and my tip of my needle is not hitting bone where I hit that little crosshair, I automatically know I'm not in the right plane. I can start making adjustments before having to go to a different view. That alone, those two little things that kind of he developed along the way doing all this eliminates, I'm not joking, like 30, 40 plus minutes from these procedures, right?
I'm sure.
That's the biggest issue is like, how do I get off plane or out of plane access? And so that's, again, another thing is using cone beam CT and needle guidance for not just that easy little case where you're going to take a needle right down the bullseye and go, right? I mean, using it for the off-angle access is is part of the way you do these cases.
Well, it's part of the skill set to develop, right? And I think for somebody that's new to the space, it's probably a little bit daunting. I consider myself relatively new to the fixation space, so it's a daunting proposition. But I think when you distill it down into a couple of basic principles, and basic is the wrong word to use, but into a couple of principles, that's super, super helpful. So I appreciate that. I don't know if you have an angio-CT. I don't have an angio-CT. Obviously, there are places around the country that do. I wonder if that's an added utility just as a problem-solving tool to, flip the patient over to CT and look with the 3D. I guess you could also always do that with cone beam as well, but then, drive the K-wire or the, whatever tool you're using at that point with CT guidance as well, to what you mentioned earlier. So, all right. So talked about patient prep, obviously. And we talked about some of the devices. When are you combining with thermal ablation? How do you decide that?
Yeah. So, that's like the next big question that's being answered, right? I mean, as a lot of orthopedic surgeons are starting to delve into this on their own at different institutions, whether or not they get IR support or can collaborate, is, who needs to be ablated? I'm very simplistic. I look at ablation as a couple things. There's very few times in the pelvis, whenever you're doing these complex lesions, that your ablation is going to be for local tumor control. You're going to combine with radiation on the majority of these, right? So then you're looking at ablation for a couple reasons. I think one, it sterilizes your corridor. So you get that 1-2 punch of radiation plus ablation along your screw trajectories and your corridors, because if you progress there, your construct fails, right? And so it's protection of the corridor more so than I think it is going to be local tumor control. Obviously, if you have the opportunity to get local tumor control, you should. A lot of these lesions are big, and so we're not going to go and ablate the whole thing. They stick into the pelvis. You've got the sciatic nerve around there. You've got the obturator nerve, the bladder, bowel loops. You've got a lot of stuff in a tight space that you don't want to have to worry about that on top of doing a fixation, right? And so I look at it as more of like sterilization of your corridors. One, there is times like especially sarcoma, you can push sarcoma lesions across bone, right? Like we're trying to get cortex to cortex and you're dragging an 8mm screw with threads through a tumor into a different part of a bone that is otherwise doesn't have tumor, right? So I think that's a big thing. IlluminOss out of the equation, whenever we were doing a lot of these just with cement and screws, it facilitates cement delivery, right? Like, you can stick your, do a radiofrequency microwave ablation in there, really create a cavity for cement deposition. You can augment with kyphoplasty balloons too, to help push some of that tumor to the wall, create that tumor dam that we hear talked about in a lot of other spaces, create space. And so to me, the ablation part of a lot of this is just that, right? We're sterilizing, protecting our construct. You're facilitating cement delivery, should that be what you want to do. Cryoablation is a little bit more challenging, right? Ice is space occupying. You're going to add a ton of time to your procedure. We do extended thaws when we do that. A lot of times, if I know I need to do a big ablation, I'm going to do that separate. I'm not going to go do a big cryo and then try to do a fixation. We're going to just split those up. And so I think it's all, relative to how much you want to do in a day. Most of the time, if you're going to do a big ablation where you want to get margins, you want to get that local control, you're going to separate it out.
Gotcha. Well, and then that begs the question: if you're cryoing and then you're cementing, that's also not the easiest thing to do. I mean, do you have a protocol around that, or do you cryo and then come back and cement at a different time? Do you not worry about the curing of the cement as much as I do, maybe?
So I do a 30-minute active thaw in the zone that I froze, and I'll use kyphoplasty balloons most of the time. Just something to get things moved out. I've not had issues with that. I don't endorse the ergo, ablate one day and then fill with cement the next day. I try to condense it down. And like I said, that being said, if I'm going to do that, I'm probably not going to do, this big pelvic lesion and then put screws through it, right?
Got it. So you may cryo, cement, and then come back and fixate at a later date, or will you try to do as much of it as you can and then come back, based on a time limit?
Yeah, so I'm, you're always conscious of how long these patients are going to be prone and under anesthesia, right? Like your patient population for this is not the most healthiest, right? That's why you're getting a lot of these cases. So you want to kind of limit that. So, I mean, the risk benefit of time under anesthesia, all these kind of things. I think, again, if I'm putting cement in and the plan was to put screws in, the cement and screws are happening the same day.
Okay.
The ablation is what you can kind of separate out depending on how much you're getting done.
I got you.
If it's a small lesion,
okay,
we're going to cryo it and I'm going to put a screw through it and it's only one corridor. You can get that all done in a timely fashion. Putting this tripod fixation where we do both columns, that's going to take you a lot longer. I'm probably not going to to do that all in one day.
Yeah, great point. Okay, I appreciate you diving into that a little bit. Okay, so let's switch gears a little bit and turn back to IlluminOss. IlluminOss or IlluminOss? How do I properly say it?
I don't know. I've heard both ways.
Okay. All right. I'm not the only one. It makes me feel better. I apologize to the company. But all right. So what is the photodynamic nail?
Yeah, cool technology. So it's a Dacron balloon. It's got a tungsten ink ribbon around the outside for visualization. And you're injecting a biologically inert resin. So as you're insufflating this balloon, you see that tungsten ink ribbon spread out. That's how you know you're opening it up, right? That's your only visualization that you have.
And you're insufflating with the resin.
With the resin, yep.
Yes, correct. Okay, got it.
So insufflating with the resin, right? And so cool device. The way I think about a lot of these procedures is if you can get a K-wire somewhere, you can put one of these devices in, right? And I'll even say if you can get your bone cannula there, you can do these procedures. So essentially you're going to do it like you would any screw. There's a couple extra steps as far as you have to ream, which is, drilling out a hole for the device to go, right? And so a screw that's a size, like say an 8mm screw has threads that get in there, right? For the IlluminOss, you have to create that space so that you can fill up the part that may not be expanding into a tumor with some resin. So you need to get resin throughout. So you have to create a little bit of space. So you're going to drill and ream, which is creating that space for the device to expand. Once you get it in place, you're going to size it similar to a screw. You want to go cortex to cortex if you can, be across the defect, and you want to fill up the balloon as much as you can within those defects. So you'll watch as you insufflate. You stick once the insufflation's done, you take a fiber optic cable essentially that goes down through the space of the balloon. And then you'll cure the balloon for, they do it in seconds. It's some absurd amount of seconds, like 700 seconds. I think, whatever that equates to in minutes. But the balloon cures for that amount of time. And then that balloon is, as hard as bone.
Wow. Okay. All right. So I want to go back so I understand this because I don't know that I fully understand this. So bone cannula, K-wire through the bone cannula. Cannula comes out, ream over the K-wire. That comes out. You drive the balloon in over the K-wire.
We skipped one step, and I'm sorry about that.
No,
so
that's okay.
over the K-wire goes a peel away sheath.
Ah, okay, got it.
K-wire comes out, balloon goes in, and then you peel the sheath away. So you're left with that Dacron balloon in place.
Got it.
Caveat,
okay.
I will say, since is that once you're kind of in position and that peel away is out of the way, Dacron on sharp bone is in a good mix, right? So there shouldn't be a lot of movement of balloon after you get the peel away sheath out. So if you've got to really reposition the balloon or something after that, there's always a little bit of worry that, I hope the parts of this balloon didn't, catch an edge or as there's a hole or rupture or something like that. So you usually try to limit any type of movement. But yeah, so after peel away, IlluminOss goes in. And that's when you'll insufflate and cure.
Okay, got it. And then sizing. How do you, I know we talked about it, kind of the size of your, reamer or that you're putting in there to create space, but what are the different sizes that are available there? I thought there were a bunch, but please correct me.
Yeah, there's a bunch. And it's interesting, right? Because I think some of them were you have balloons that have tapers as well, which are interesting because there's balloons that are tapered towards the back end that if you think about, they were designed for fragility fractures in the humerus. So you have the back end of the balloon that's a lot larger than the distal end of the balloon. So you're dealing with some of that. So there's kind of some area specific ideas that they were, using whenever they developed the device. In the pelvis, we use a lot of straight ones. You will grab the tapers sometimes when you need length. So the length and width are all a little bit going to be kind of user preference, I guess you could say. I say that because any of the balloons too can be foreshortened if you want to. So my theory is that I want the largest balloon diameter for the lesion I'm dealing with, regardless of length. I want it to go cortex to cortex, but I also want it to be, I think the biggest is 22 millimeters. I want a full 22. I don't want to be at 15 just because, the balloon was too long and I got to go with a shorter one. There's techniques to foreshorten the balloons. And so I think that's worth everybody's while to kind of at least know exist because we do it not infrequently when we're using them.
Okay, got it. So you are commonly picking a longer balloon because of the extra width to fill that osteolytic space effectively, the tumoral space. Yep. Okay, got it. And then so obviously lytic lesions. Is there a role for blastic lesions? Can you create enough space? Is it even worth pursuing?
Blastics, I don't see, this fitting into the blastic space. The question comes up is what do you do for the mixed lesion, right? You've got areas that are blastic lytic, some of these post lung cancer treatments, post prostate cancer treatments where you have that kind of bone that is the mixed. I really think for some of the mixed stuff, I would go with traditional screws and cement. Blastic, I think screws are great, just because you really can't get that opening of the balloon, right? I mean, and that's where, we kind of touched on it earlier, and we'll look at some of the cases at the end, but that's where I think that this as a combination device is awesome, right? You can have areas where, parts of the bone look good, or maybe a little bit blastic where a balloon wouldn't open up as well. You put a screw through there. The other parts you can put an IlluminOss in. With the needle guidance software, you can make your lines intersect, right? So we're frequently intersecting and drilling through our IlluminOss devices to kind of anchor these constructs in place, cool. Right? And so that's where I think the possibilities are kind of endless with this, right? I mean, we could develop these constructs where you wouldn't otherwise have been able to do it. And it's all with the needle guidance software and understanding your devices.
That's super cool. Okay. All right. That's good to know. And again, as you said, we'll talk about this a little bit as you show some cases, but just some very basic questions. This is not a laser. Are there light precautions that we need to take?
Nope.
There's none, right? Okay.
Nope. There's usually just a lot of photos taken whenever the fiber optics come on. It's a bright blue light. They turn the lights off in the room.
Cool. All right. So it's like a disco, right? It's like, yeah. Okay, cool. And then any thermal energy released, like cement?
There is a little bit. It's not overwhelming. It's not going to cause injury to the joint space. It's not going to cause injury to the nerves nearby. There is a little that happens, just like with cement, right?
Okay. Got it. And then not everything is straight, right? So how do you deliver a device like this into an area that's, I guess, somewhat curved or nonlinear, if you will?
Yeah, again, another spot where this device can excel, right? So within the pelvis, and when you're doing these cases, even in long bones too, depending on where you enter and the trajectories you take, the IlluminOss device goes over a very thin K-wire. It's like a 2 mm K-wire. That K-wire has a ball tip on it. So essentially you can push it through the medullary space and it can take the curve of a pelvis.
Fascinating. Okay.
Sometimes that's hard, right? Theoretically, all these things always work out, But whenever you think about it, if you have a big lytic lesion, your ball tip's just going to go right through it, right? And it could go out into anywhere. So that's where, again, using needle guidance, being able to get yourself across these trajectories and then into area of bone where that is going to be contained again, right? And so that can sometimes be a challenge. The pelvis is curved too. Women's pelvis, those curves can be a little bit more challenging, and getting a straight K-wire, a straight object across a curve is otherwise difficult, but K-wires can be bent a little bit. So there's a lot of those little tips and tricks that, you learn from ortho, right? You can bend the tip of a K-wire, and as you're advancing it through, you can get it to take curves around areas. And so all this kind of just comes with the more you do, the more you can kind of push and figure out what you can do with all these devices. But yes, this device is going to excel in areas where you can curve it around different areas.
Okay, got it. That's fascinating. I guess the similar concept is, sharp venous recan, right? And it's not uncommon if I have not that I do a lot of venous recan anymore, but, and historically when I had cases like that, putting a little bit of a curve on the tip of the 21 Chiba or whatever, and just to kind of point in a different direction can help. So I guess similar to that, but great points. And again, collaborative space, as you said. Any precautions with the photodynamic nail of the IlluminOss device?
Yeah, the one kind of issue that you have is, again, as you're repositioning or you worry about something rupturing the balloon, is as you're injecting all of that resin at the beginning, there's this time where the whole device isn't expanding yet, and you can get a decent amount of resin in, supposedly biologically inert. I don't want a whole bunch of resin that may or may not cure when we put the light of a different balloon up in there, right? And so I think I have a lot of caution around that part of the case. And so I don't want that device
spill in outside the balloon. Yep. Effectively. Yeah. Okay.
Yep. I haven't personally had one rupture. I've heard of people that, have had to deal with those kind of issues. It's one of the areas where I think that's a limitation of the device, is that Dacron balloon is not very robust. And so you got to worry about that. Other than that, there is literature out there, right? But it hasn't been a lot of literature in this space where we've been using screws and cement, which we know is a very stable construct. Biomechanically, it's very good. IlluminOss is also very good. I haven't seen many cases of, devices rupturing. You're not going to have the issue of it backing out, right? Like you can with screws. So, there's a lot of good things about it. And it's a little bit easier for orthopedic surgeons to then put other devices into. So I think there's probably more positives about it now than anything. So.
Okay. Got it. So we talked about when to use an IlluminOss device, right? Delitic lesions. And, so when would you, outside of blastic lesions, when are you going to choose a plate and screws, a nail rod screw type system construct versus an IlluminOss?
Yeah, so good question. I think, the standard, if we just take the pelvis, because that's kind of easy right now, because that paradigm's changing a lot. And we recently have an article that should be coming out soon in JOS for comparing our constructs to the Harrington reconstruction of back when, right? And so you look at that and you look at the IlluminOss device and just pelvic fixation in general for that is we've been able to take somebody that, the Harrington procedure, which huge incision, a lot of surgical morbidity, long time recovery, had to delay chemotherapy, had to delay radiation. You could only do it to the very best of the patient with metastatic disease, right? And now, we're doing it to people that are on chemotherapy, that have radiation right after. And we're doing these reconstructions and allowing other reconstructions to happen after, right? And so I think that's been huge.
That's really phenomenal, and just great work for you and the team and the individuals that are doing these type of interventions around the country and around the world. I mean, that's phenomenal. But this is what IR does, right? It's filling a need in a space where a patient may not have another option. So or especially with a newer device. That's great. So it sounds like the space is evolving. We're not the IlluminOss nail is not fully replacing other constructs, but there are avenues where it has benefit over other constructs. Would that be safe to say?
Yeah, I think so.
Okay.
It's probably a little bit easier to fully go through some of the decision making with some of the cases. But if I'm trying to tie the anterior and posterior column together, like let's say we've got lytic disease that's involving both columns, but really not extending up into iliac. So I know that posterior to anterior corridor that we're going to put a screw through to really kind of add stabilization doesn't necessarily go through a bunch of lytic disease. I'm not going to use an IlluminOss in that. Say we have lytic disease in the posterior column that extends up. I'm going to extend that IlluminOss up, and then I'm going to put my P to A screw right through it. And we're going to tie all that together, right? So I look at IlluminOss as a device to eliminate the need for cement of uncontained lesions within the pelvis, right? You got this big lytic defect right on the back wall of the acetabulum. Maybe the wall of the acetabulum is eroded away. You start putting cement in here, you could very quickly have to stop, right? It's going to start leaking. It gets close to the joint. You don't want to get it all in the joint. So you could be limited on the structure you get there. Other caveat, and not to beat a dead horse with this issue though, but is that, if you can supply your orthopedic surgeon with one really good column that they can then put a hip implant into if they need to later, total hip arthroplasty, you've taken them from where they've had to do a huge reconstruction to now easily can screw into this device. They're not having to chisel away cement. They're not having to ream out metal. Totally different. And so you kind of change the paradigm of the way they can address some of these disease processes. So they can use conventional methods to do a total hip when before they could.
Got it. Super cool. So then do you ever feel the need to cement around an IlluminOss nail?
So I don't. I haven't. You can. People do. I think it's more the cement for me is filling those defects around my screws, keeping the screws in place. There's times when I think the traditional screws and cement's the best way to go too, right? I mean, but I don't think that in our current practice that we've had very many instances where we've added cement around IlluminOss. We have cemented when we've combined screws and right? If, we're trying to deal with just the screw fixation with cement.
Sure.
Part.
I got you. Okay. All right. That's great to know. And thank you for kind of diving into that. I'm sure we'll dive into it a little bit more with the cases here in a little bit, but I want to switch gears real quick. Engaging stakeholders, right? Not all, very few of us have the well-developed practice that you have. Obviously, you have put in a significant amount of time and effort into building that practice and ensuring positive, proper patient outcomes and patient follow-up. So that, again, kudos to you and your team. How does an early adopter get into this? How do we talked a little bit about the multidisciplinary tumor boards, the teams, the discussions. Where do you start?
Yeah, I mean, I think having the full MSK repertoire is great, right? And I'll use my fellows that leave here as an example. Usually within the first 6 months, I'm getting a call about, hey, a celiac plexus neurolysis, or they've engaged the palliative care team, or a hemonc has called them about this, this patient that may just need a nerve block, right? And so you go in, you help problem solve, you start developing those relationships. Within about a year and a half after those conversations, I start getting calls about screw fixations and complex ablations from those fellows, right? So I think there's filling the gap in the help with palliative care is probably the easiest way an IR can get into this, right? Understanding that through that is, seeing patients and inpatient consults. Having a clinic is helpful, right? I mean, it's hard to do cancer care without having a clinic. Can be done
for that matter, right?
Follow up, right? Yep. And so a lot of this starts as developing just a general MSK IO pain practice, right? Because every time you do something and you help out and you have a good result, it's gonna be like, hey, I wonder if IR can do something about this, or hey, can we do something about that? If I can tell you the ideal scenario, I think is what we have here at MCW, and much to Sean Tutton and his team the team earlier before me that built a lot of this. But our fellows are integrated; they rotate through palliative care. We do a lot in that side. We're integrated into the cancer clinic. We have an MSK tumor board, or the ortho-onc, hem-onc, rad-onc, we're all there. And so there's constant communication, and so that keeps kind of everybody on the same page. So that's ideal, right? But I think if anything, to start this would be engaging a local ortho-onc, if that's possible, if you have one. And then the hematology and oncology, those are the ones, the hem-oncs or med-oncs, they're going to be the ones that are going to be sending the majority of referrals, right? Multiple myeloma is a huge patient population that requires, intervention. We do a lot with the multiple myeloma patients. And so those are going to be where you're going to get those direct referrals. A lot of those, and what I see in questions I get, is these outside IRs who may not have an engaged ortho-onc, but are getting, cases sent to them from their oncologists that are these complex cases. They're like, hey, ortho's not going to do anything about this patient. It's already been radiated. Like, can we do anything? And that's where all this starts, right? And then all of a sudden you get familiar with the device. Say it's IlluminOss, say it's screws. You start doing these cases, and then all of a sudden you've got this huge practice.
You made several fantastic points in everything that you just said. I think that doesn't just apply to new grads, right? Even for me, I'm 12, 13 years into practice. I started at UAB about 2 years ago. It's rebuilding practice patterns and educating the stakeholders in the hospital of what IR can do, and some of the things that, are maybe a little bit newer in the IR space, but are unknown to the other, specialty teams, right? And then it's not always the MSK multidisciplinary team that is referring some of these patients, right? A lot of my CLECs are going to come from pancreatic tumor board, and the pudendal and impars blocks and neurolyses are coming from rectal cancer or pelvic tumors, things like that, right? So a lot of value in the block neurolysis practice, in the spine practice, as you said, kind of being that comprehensive pain practice. For lack of a better way to say it, I equate the IlluminOss system and device almost to spine jack a little bit in the spine, right? And containing cement within a, kind of moth-eaten vertebral body. So there's a huge value, to your point, in just that comprehensive pain practice and offering everything, and then continuing to branch out into new interventions and new parts of that practice as you guys have done. So great point. Okay, literature. I know I mentioned it earlier. I was surprised, and saying there's a lot of literature on this system that's probably not the right thing to say, but there's not a small body of evidence. There's a fairly significant body of evidence supporting the use of the IlluminOss device, right? So let's go through that a little bit. I know you sent me an article from Lozano Calderon from 2024. It was 30 patients with a pending or actual pathologic fractures of the pelvis, looked at 12-month outcomes, and had fantastic ECOG improvements, VAS improvements, functional improvements, pain interference scores went down, right? They had no nail failures. Was that helpful for you? You already have a well-developed practice, right? But can you now take this body of evidence? Is it enough to then go to the multidisciplinary team? We should be using more of this data.
Yeah, absolutely. It's hard with this data. And like I said, we have kind of this paper coming out that's comparing it back to the old way, but this is where we always struggle with retrospective data. I think this Harvard one was one of the few prospective ones we have on this procedure and the way they use it. And it's data that confirms what we've seen over the last decade, right? Like, we see patients that have been non-ambulatory for months and months coming to this that are like walking the next day. And we have those types of outcomes. So it's great to see it on paper. I think regardless of whether this is IlluminOss or the screw and glue or the screw fixation techniques that you have, it confirms that taking somebody with periacetabular disease and doing this procedure is going to help them, right? So what we've done is you're taking a population of patients that had been traditionally almost neglected by the system as far as radiation, medical management, despite lytic defects or structural defects being there because the Harrington was too much for them to handle. Or now we can see that you can have a huge improvement, right? I think with this paper, 100% of the patients were weight bearing at 1 year, which is huge, right? And 89.3% were weight bearing at day 2. Improved ECOGs across the board, right? And so that is amazing, right? And those patients are in every hospital system right now. Like, we don't know how many of those patients exist, right? They're everywhere. And so there's a huge patient population that can benefit from this, right? And we all have the skills to do it. So I think it's on us to try to figure out how to make it happen.
Absolutely, right. And going back to that data, right, the European registry from 2017, that was 132 patients, in the majority in long bones, not even in pelvic pathologic type situations, pathologic fracture type situations. There is randomized controlled data for fibular fractures between screws and plates versus the IlluminOss nail, right? So there is a fair amount of data. And again, kudos to your team and everybody involved over the years in putting out that data set, where I think we're all excited to see that paper when it gets published and help adopt in our local practices. So unless there's anything else you got, why don't we show some cases?
Yeah, let's do it.
All right, Brandon. Appreciate you pulling these cases, providing these for us. I think great cases to complement the discussion we just had. Why don't you walk us through this first case? If you remember, do you know what the tumor type was or anything about the patient?
Yeah, so this was a metastatic renal cell carcinoma. So this patient's going to be radiated. We're going to ablate. Typically for this one, we'll do an RF ablation overlapping, or you can kind of stagger 2 RF probes behind, one in front, one behind, to get these lengthier lesions. And so I think this is a very basic kind of anterior column disease, right? So the lytic lesion's confined to only the anterior column. We don't see it extend up into the supraacetabular region at all. So this can be like a single screw case, right? And so from this one, patient would be prone, and we'd use needle guidance software to kind of come along this one. So let's go to the next slide. So this is a little bit of what I was talking about with the overlay. So we use these polylines here to kind of trace out the tumor. So you can just envision that you don't have those there. You kind of know where the lesion is, but you're not really sure where it starts and stops. Again, this helps with all that tactile sensation too, right? All of a sudden you're driving your cannula in and you get to where that tumor is and you lose feel, right? Like all of a sudden the needle just starts going. Is that because I'm in the middle of the pelvis? Is that because I'm in tumor? Having that there, that really helps. Also for ablation probe placement, right? I don't have to do a spin or worry if I'm where I need to be within the tumor. If I'm doing 2 probes, staggered, I can just position them based on those lines that are there, right? That's the ball tip K-wire that I was talking about earlier. So you can see, it's pretty atraumatic. It's not going to break through a cortex. You can use that to go around space. If you look really closely, right where the K-wire meets the bone is that little crosshair that I was talking about that we use to help assist with needle guidance.
Got it. Okay. I see what you're saying.
And so let's go to the next one.
Okay. Real quick, what are you using for RF?
We use both. So I use Osteocool and Optoblade. I'm trying to put Optoblade through the ringer and see. Osteocool is a great device. How much of a difference the internally cooled versus externally cooled helps with, not sure. That slide we just saw before, that was the IlluminOss device being filled with resin. So this is the view you get. This is that tungsten ink ribbon expanding within that lytic defect. You can just see how it fills that defect nicely, right? Like right now, you're not worrying about cement extravasation. You're not doing that's not in the back area. You're just filling up this device, right? So one concern I did have with this case was, were we extending into the acetabulum? And so if you go to the next slide here, you can tell that we were actually, right? So you can see the left-hand side of the screen shows the device fully expanded, and it is encroaching within the joint space. Beauty of this device, we just pulled out some resin and then did a repeat cone beam CT, okay. And now that encroachment's essentially gone. We still have really good fill within the lytic defect, and you can see how it's filling this uncontained defect, right? So you can imagine how tenuous it would have been to get really good cement in here.
Oh, for sure. I think without that cortical acetabular roof, I don't know that I would hesitate to say that you would have just leaked a bunch of cement into the acetabulum, right?
Yeah, you would have had a high risk to do it, right? And that's something you don't necessarily want to do. But so the device is adaptable too, right? Like you're not stuck with the amount of, until you cure it, you can pull the resin out. You can do what you need to do.
That's fantastic. Okay, cool. And was there another? Yeah, okay. good.
Yeah, so this just is another demonstration of how it fills that defect, right? Like, I think this is a perfect case example of how IlluminOss can excel, right? Fills a good lytic defect. It's going to provide good stabilization of that anterior column, and it looks good when you're done.
That's super cool. And then obviously there's a little tail kind of coming out of the cortex at the axis site. I assume this was a longer device that you then foreshortened, as you mentioned earlier?
No, I think this one just ended up the way we had it positioned. Again, like, I'm not going to put a lot of forward pressure on these after we've taken the peel away out. It's a little bit proud. This patient's not going to notice it there.
Okay. Got it. Fantastic case. And then why RF instead of microwave? I mean, is the traditional thinking of just RF in the bone being a little bit more controllable, or is there another reason for you?
Yeah, I mean, for me, I think so, right? I think of microwave in these scenarios. Like, if you look at where that was, the obturator nerve is right underneath where we were blading. Is it a huge thing to lose your adductors? Like, not necessarily. I don't want anybody to be worse off after a procedure, right? I mean, any type of nerve loss, I always talk to them about the potential loss of adduction after we do these. It's not the end of the world as far as ambulation goes for them, right? I mean, they'll still be able to do everything they want to do. They'll just have a little bit of weakness. But for me, for RF, the cortex is still kind of intact there. So I think, leveraging the oven effect that we talk about with RF is another safety feature for me. No manufacturer has really spelled it out well enough to where I fully believe, the size of ablation I'm getting within bone and soft tissue outside of the liver and kidney, right? Like, there's no bone protocol for, how many watts or how many minutes versus the lesion or the tumor type. So a lot of it is, how comfortable you are using it in that space. Do you use microwave? Usually it's for the really big tumors that, you would have to do 3 or 4 different pullbacks and from different angles to really get in. Then can you spend 45 minutes ablating or 15 minutes ablating at that point? So
yeah, great point. Well, I'll also say, I mean, I've said this before on the show. It's actually one of my pet peeves to use the manufacturer's suggested ablation zone size, because it's not all. I mean, most of the time it's done in ex vivo settings at different temperatures, right? And so I really, definitely when I'm in solid organs, I will take that and I will literally throw away that chart. I'll just use it as a guide. And then I'm looking in real time or using some sort of ablation confirmation software or other, modality to gauge how big my ablation zone is. I just never rely on the chart, and I always try to articulate that as well. But that's a great point, and a super, super cool case, man. That's very cool. Awesome. Should we go to the next case? All right. What do we got?
So this was a non-small cell lung cancer, and this is an isolated kind of posterior column disease, right? So we have the whole ischium, you can tell, is blown out. Again, uncontained defect extending into the acetabulum, medial wall, the pelvis. Looking at this case too, though, is the proximity of the bladder. One thing we didn't really talk about whenever we were doing the prep thing is a lot of times, especially if you're doing an anterior column, you should put a Foley in to make sure that bladder's not pushed up against the sidewall. But
for this patients are all under general, right?
Correct, yeah, because we rely heavily on the use of the needle guidance, so I don't want any misregistration to occur or them moving around. We've done some under moderate anesthesia, what we call monitored anesthesia care, which is propofol or total intravenous anesthesia. Those patients tend to still move a little bit, so you have to deal with that, but can be done.
Okay.
So this particular one, isolated, essentially posterior column, uncontained lytic defect. You can go move on to the next slide here. Again, rinse and repeat. You'll see a lot of the same stuff from us, right? We use that triangulation method for skin entry and for bone entry on all these, because these are all off axis, right? This is going up from underneath essentially the butt cheek, and you're coming up into the ischium. And so you can see the tumor we have roughly segmented out. That helps for the ablation part of this.
Sure.
And then we have our needle guidance line, our posterior to anterior corridor screw, which is going to be on the far side. We wanted that as close to our other K-wire as possible, because the idea was we were going to intersect the IlluminOss that was going to go through an uncontained defect, and we were going to lock it in with the screw through the posterior to anterior corridor. So that's the needle guidance view that we get. That's how accurate you can be if you want to do that kind of case.
Explain to me, again, I'm the novice here, so explain to me why you need to lock it in with a PA corridor screw, and please, correct my terminology if I'm incorrect, versus the first case where it was just an anterior column, IlluminOss.
Yeah, so the posterior column, it takes a little bit more of the brunt of the weight bearing in the acetabulum. There was a little bit of lytic disease that extended kind of superiorly. So a lot of times, even though I usually think of this as single column or both column disease, right? If it's a both column disease, anterior and posterior, we're always putting in a P to A. If it's single column disease, it's plus or minus. One of the papers actually that was published by Sean Tutton and Dave King was a biomechanics study using this construct, the P to A initial, and they looked at how strong it was within the pelvis. And for their initial papers on screw fixation, and this was a really strong construct. So to me, whenever you have disease that kind of extends up above the acetabulum, especially in a posterior column, we're going to more than likely put that P to A screw through there.
Got it. So IlluminOss goes in, insufflate with the resin, cure the resin, and then the P to A screw goes in.
Yeah, and usually what we'll do is we'll back our K-wire out, and so or partially out. So we have the IlluminOss, we have our access into posterior column and that P to A corridor. We back the P to A corridor away from the balloon so that there's no sharp objects around the balloon when it insufflates. Then you insufflate, cure. You can kind of manipulate if you were a little bit off and you want to try to get back into really teeing into your IlluminOss. And so then we'll hit the IlluminOss with our K-wire and then drill over and through the IlluminOss and then put our screw in.
So the goal is to go through the IlluminOss.
For these, a lot of times, yeah. You can go next to it. So the other thing you can do is if you're really tight, you can leave your K-wire there, the smooth part of the K-wire, and then you can insufflate the IlluminOss around the K-wire. So the K-wire is kind of indenting, and then your screw is going to seat into it, right? On this particular one, I didn't think there was a ton of space. If you can see kind of how constrained that IlluminOss is up where the screw is, there wasn't going to be a ton of expansion. So the idea was that I wanted to kind of go through it.
And really bite into it. Okay, that's a great point. And do you feel any resistance going through the IlluminOss device?
Not after you've drilled through, right? So your K-wire is going to hit it. It's hard. I mean, it's the equivalent of like cortical bone almost, right? So you're going to know you're on it, and then you drill through, and putting the screw through it after that is not hard.
Okay, all right, good to know. Very cool, man. Next case.
It's another metastatic lung cancer. Let's see. Oh, so this was an interesting one here. So you've kind of got a pathologic fracture that's non-healing of the superior pubic ramus, kind of mid-ramus, not really much extending into the periacetabular region. Let's go to the next slide. You also have a non-healing fracture of the inferior pubic ramus, and those are traditionally really hard, right? There's not a lot of constructs that work here. This was kind of a one-off case, but I just kind of wanted to show the versatility of some of the things that we do. So the obturator ring is really hard to fixate. Most of the constructs that you do fail. There's a lot of tugging on the bone there. This one was done recently, so I don't know exactly. Patient's doing great. I don't know the longevity of what we did, but the idea was how are we going to fix both the superior pubic ramus and inferior pubic ramus, right? So again, prone approach, set up the same way we always do. You can go to the next slide. So this was a look at the K-wires we put in. So anterior column K-wire is going all into the pubic body there. And then we did a kind of an off-axis inferior pubic ramus screw, and then we're tied that together with the traditional ischial or posterior column screw to help kind of just reinforce the ring there, right?
Got it.
So we'll go to the next slide.
Got it. And then although, I mean, obviously to the untrained eye, this looks like you're breaching the acetabulum. I assume in three-dimensional space, it actually is not breaching the acetabulum.
Correct. Yeah, no, we're not through the acetabulum. And I will say one thing about that is a rule I always tell my fellows, which is something I picked up from an ortho lecture way back when you're looking at the pelvis and you're putting your K-wires in, it's the one time in radiology where you only need one view to prove you're not in something. So if you can show in one view that your K-wire is not going through the acetabulum, you're not in there. Obviously, every other time you want to show two views, you're where you think you are. But this is the one time where if you can just get one good view that shows a gap there, you're good to go.
Great point.
So this is the construct we ended up going with. We put an IlluminOss in there, foreshortened it. You can see it expanded across that kind of lytic defect, and then we tied into it with screws from two sides. So again, I just think it speaks to like the versatility and creativity that we're going to be able to have moving forward with these different devices, and the problems that weren't traditionally fixed that can potentially be fixed now, right? And all of this is driven by, the fixation technology we have, the skill sets people are developing, and the imaging technology that we have, right? Like this is all done with image guidance. This is an awesome result for what we had to deal with as far as trying to get all these devices in there and along certain trajectories.
That's a fascinating image. And I guess the reason to drive two screws through the device were to just kind of lock in that tripod, if you will, and to fixate that entire space. I mean, I assume if you had two IlluminOss devices and one screw just wouldn't have the same level of fixation?
Yeah, honestly, hard to know. That was we want to, across some of these defects and lytic lesions, put cement. There was no way that cement was going to stay near that inferior pubic ramus screw, right?
Yeah, gotcha.
I mean, it wasn't going to, and that was the thought of putting an IlluminOss there. Could you have put 3 screws in there? Probably would have worked. Yeah, you wouldn't have been able to put cement in. So again, this is one of those things we're trying to feel out, like, how and where you should use this device, right?
Great point. So there is cement along these other screws as well?
No cement on them.
Okay, I'm sorry, misunderstood.
We elected not to, yeah. So
Okay.
This was the one where we could have put a little bit of cement as that superior pubic ramus, but we felt with, this is a partially threaded screw, right? So you can use that to help reduce that little bit of a fracture that we had there.
Got it.
So that's main. Wouldn't have been wrong to put some cement at the end of those to help keep them, we call that potting them in, to help keep those stable. But we felt with locking into the IlluminOss that we didn't even have to do that.
Got it. Okay, so you're using that partially threaded screw to then compress the fracture plane back together. Okay, I got you. Very cool. All right, next one.
Yeah, so this is a patient with metastatic thyroid who all of a sudden was developing all this right lower quadrant pain, and turns out it had nothing to do with anything other than this big bone lesion that was there.
That is fractured.
Interesting case, yeah, not subtle, right? So this brings in a couple things, and granted, we're working with orthopedic surgery here, so this is a little bit more outside the box of a lesion. This lesion needed some reduction, right? And so you don't have things in line. This isn't a traditional case that we would take on, but because of the collaboration, the number of cases we thought this was something we could try to do perk. This patient actually underwent, I'll pre-op embolize a lot of the vascular lesions.
Yeah, sure.
So this patient underwent a pre-op embolization before we started the fixation part, but you can see this is mainly an iliac wing problem, right? So this is going to be a non-traditional, fixation. I think when you're thinking about these types of fractures, you've got to get perpendicular to the fracture, right? I mean, you got to be able to get screws across there to really fix the fracture in place.
And normal bone, as you've already said, right? So
yeah, and then you got to figure out how to get some of these fragments reduced back into place if you can. So let's go to the next slide. So this is a 3D rendering of what it looks like. We've got this uncontained lytic defect. When you're thinking about these cases, you're like, okay, if I did put cement there, what would happen, right? It would just kind of, who knows, go out everywhere. So this is one we were going to try to incorporate IlluminOss in from the start. Let's go to the next one. So this is where our needle guidance trajectories. What's really not shown here is a little bit of finagling on the front end, was that we started these trajectories into the fragment of bone and then use those to kind of joystick the fragment up onto another trajectory, if that makes sense.
Okay, and kind of fulcrum lever the fractured fragment into better plane, if you will.
Into a better plane, yeah, right. So there's kind of 2 sets of needle guidance lines. The first ones were getting into where we wanted to in the fragment of bone, and then the second ones were connecting where we thought those fragment of bone should go. And so once you engage the floating fragment, they were able to kind of joystick it onto the second set of guidance lines where we could get it in place,
cool.
right?
Okay.
So let's go to the next slide. So then next is compressing the fracture, right? So this is a different partially threaded screw. This screw has threads about 2/3 the length. That just shows you only need the smooth part of the screw across the fracture, right? And I want as many threads as I can on the distal end. So this one was solely to put as many threads across the fracture. The other thing you'll notice on here is there's a washer. So usually when we're compressing down,
okay,
we add a washer. You can add a washer also if there's, just poor bone quality where you're entering, and you may just end up sending that screw straight through the cortex. Washers help. And then you can see on the bottom part where we had the tumor segmented out and the ablation probes in position to do, this was an overlapping ablation. I send the probes 5 millimeters from the anterior wall of where that lesion is, and we pull back and ablate. Other little variation, we had partially inserted one screw, the other one's kind of going through a cannula. So you can use your partially inserted screws to do ablations and stuff through. We do it from time to time.
Fantastic.
We'll just send the K-wire back through after that.
I gotcha. How the hell do you get a washer through soft tissue like that?
It's interesting. It's not too hard. You obviously have to make a little bit bigger incision at the skin.
Okay.
But it goes through your tissue plane.
It does. Interesting.
It does. Yeah. Okay. Surprisingly, for all intents and purposes, the screw's gone through there first. And so you have, a big, 7 or 8 millimeter screw that's created a gap in that tissue plane for the washer to go through. I'm sure it pulls some little soft tissue fragments around, as on the bone surface there, because we're not creating, we're not open, right? It's not like the bone is cleared off where we're putting that on. But actually the hardest part for us in IR is getting it through the skin surface, because I'm just not used to making, the incisions big enough to get it through there.
Yeah, great point. Great point. It's funny. I tell all my fellows I'd rather have a big incision than a small incision. So especially for, anything that requires a large device like a bone cannula. So great point. Next slide.
Yeah, so this is what the construct looks like after. I think ideally we would have probably engaged the IlluminOss a little bit more, right? Like this is the IlluminOss is not engaged with the screws, but we've reduced the fragment into a decent position. We've compressed it down with partially threaded screws, both above and below, and you can really see it fills that lytic defect, right? Way better than I think it would have done.
Yeah, absolutely. And then how did you decide 2 screws and 1 IlluminOss?
Yeah, so I think of IlluminOss as filling the purpose of fixation across uncontained defects. And I can do that with a screw. I mean, if a screw is going to work for that purpose, other places for fixation, I'm not going to use an IlluminOss to directly replace every screw I put in. I think I'm going to use it to limit the amount of times I have to cement in areas that are difficult and or it won't produce a great result. And I think that's where IlluminOss is going to kind of fit into the picture more.
I guess why bracket it on both sides with a screw? Was there a specific reason, or it's just a larger area?
Yeah, the screws for here were for compression too, right? We were trying to reduce fracture fragments, and you wouldn't have been able to do this with just one. You needed multiple because of the size of the fracture to prevent any type of rotation. And so this was, we were going to put three types of fixation across this no matter what.
Got it. Just with the length of the fracture plane and the deviation, I guess, of the fracture. That's, wow. Nice result. That's beautiful.
Yes, and this is the post 3D rendering. So you can see those fracture lines have closed down. It looks to be in a little bit better alignment. The IlluminOss is really filling that defect. So I think pretty good result.
Absolutely. And then to your point earlier, the superiormost screw has less threads than the inferiormost screw, probably because of the complex fracture planes, I assume, right?
Yeah, so you can see the fracture plane on the top part extends almost to where those threads are, right? The distal thread. So you're really kind of compressing two fractures there, or 2 fracture lines, I should say.
Beautiful case. Okay, now we got a sacrum.
Yeah, so this defect actually comes up more frequently than I would want. So it's, what do you do with this, right? So
100%, absolutely.
I've had patients where on the younger side, this is myeloma. I had a lady that was 55, metastatic RCC, very similar lesion. She's one of the few I've seen fracture an 8mm screw in half, right? We put you can put screws across there, and you try to get cement in, but like, where do you stop? How much do you put in? It's really hard. We put a little bit of cement in hers. We ended up having to come back and reinforce her sacrum with more screws. So the question always with this is, are transiliac transacral screws through S1 and S2 enough? I think we would like to have something more. So if you go to the next slide. So this is kind of our idea, the way to fix this, right? We're using IlluminOss to replace cement essentially in this, and to add a little bit extra rigidity to the construct. So from a long axis approach, as if you were going to do a long axis sacroplasty, we put a K-wire up, run it to the anterior surface of S1, and then you can lock it in just like you want to. You can go cortex to cortex. I think we left this one a little bit short because we were going to lock in with the screws going across. Again, heavy with needle guidance, right? Like all of our K-wires were hitting each other, right? So we were able to hit our K-wires from S1, S2 and intersect the one coming up on the long axis of the sacrum, deploy the IlluminOss, and then we run screws through S1 and S2. So you'll see that on the next slide.
Got it. And then this was CT or cone beam CT?
So this is CT.
This is CT. Okay, got it.
So I'll do my sacrum cases in CT just because of the complexity that's there. And if you can see from these images, I mean, you can get your devices to cross, all right? So we have screws going through the IlluminOss. We've eliminated the need for cement, and we're transmitting, that force through the sacral ala the way it's intended to be, right? So all the force from the lower extremity comes up through the acetabulum. It's going to go cranial, posterior, and medial, right across the sciatic buttress. It hits the SI joint. It goes up the sacral ala and into the L5 transverse process. So anything you can do to reinforce those force vectors, which is what the tripod is doing with the columns, and which is what we look at whenever we're reinforcing the sacral ala here, or the sacrum with these S1 and S2 screws, adding that extra bit of reinforcement within the ala, which is a area of the sacrum where force is transmitted is helpful, right?
Yeah, absolutely. That's a beautiful case. And yeah, to your point, I mean, if you just do a traditional sacroplasty, how much benefit are you really going to add with a lesion like this, right?
Yeah, this is a hard lesion, right? And again, this is the great part about IR, the great part about collaboration, and the even more better part about all these new devices coming out is we can start thinking about these lesions in different ways.
Great point. Great point. Do you ever worry, I mean, or at least I didn't see it on the slides, you didn't ablate beforehand for this lesion, correct?
No, typically in myeloma, we're not doing a ton of ablation. We will for plasmacytoma. I know there's some newer literature that's coming out, but, with people doing more ablations in myeloma, I don't think it's wrong. I just don't think it's just, there's as many people doing that.
Well, and I guess the only reason I ask is, clearly you have cortex that is destroyed around this lesion. And we talked about it briefly before, do you worry about just kind of squeegeeing tumor into the sacral foramen or elsewhere around the sacrum in a situation like this, or it's a small part of the case, patient's in pain, and this is what needs to be done?
Yeah, not traditionally. I tend to not worry about that as much. I know there's some of the spine literature with kyphoplasty showed that, there was some epidural spread after, and you can, see that in some of those. I don't think about that too much with the myeloma here.
Very cool. No, beautiful case. Okay. And this is just the last shot, I guess, right?
Yeah, just a 3D rendering there to kind of show the whole construct.
Okay. One more, I think. Go ahead.
Yeah, so last one. So metastatic lung cancer, post-radiation, had progressive disease. The initial lesion ate away the whole posterior left iliac. Then the progression started to eat away in the sacrum. And so again, you're left with, and this is what we talked about in our MSK conference, is like, what do you do here? Right?
And you have disease on the right side as well. I don't know if the patient was symptomatic on the right side. I assume more left side than right side, but yeah.
Yeah, well, symptomatic on both sides. So we treated both sides. I mean, for the sake of this and for the talks I've used this case in,
Okay.
We kind of focused just on that left side. We did ablate and I think cement on the contralateral side. But it's what do you do here, right? So can you just put cement in the sacrum? You can't fixate that side of the sacrum. You can't fixate anything in the posterior iliac. So what we decided to do was to use IlluminOss to reconstruct the posterior iliac and then use the reconstructed posterior iliac to fix the sacrum. So here was the needle guidance trajectories that we had planned. So we had tandem or double barrel IlluminOsses coming from a posterior to anterior trajectory through the iliac wing. And then we were going to bisect that from a contralateral approach with screws in S1 and S2.
Okay. Got it.
So if you look, here's the start of that. So there was the left side, there's one cannula in there that's treating the lytic disease on the left side that you had noted. And then we sent K-wires, on the right side. Then we sent K-wires from right to left and we stopped them short of the lesion. We did all this in CT. So you go to the next slide. And then from a posterior to anterior approach, we put IlluminOsses along those trajectories, deployed those, cured them. This is the K-wires that were pulled back. And then in the next image on the right here, you see the screws extending through the IlluminOss. Yeah, no. And then you can move on to the next slide. You can see what the construct looks like, right? So
that's beautiful.
You have the IlluminOss, which actually is almost going into the confines of where you would expect the iliac bone to be, right? And then you can see those, the screws are through their appropriate corridors and they're bisecting and they're locking in that IlluminOss. So this is, again, as with the last case, I say this is the creativity and kind of the things that we can do or that we don't know we can do yet with these devices, right? This is totally awesome. And this is due to years of collaboration at MCW with the orthopedic surgeons that we've had here that we're able to kind of work together to come up with some of these things. And then we use the technology, having the technology to pull it off is the next step, right?
Yeah, absolutely. Well, effectively, you've rebuilt the posterior aspect of the iliac wing, right? Which you could not have done with the screw and cement to many of the points that you've already made. So that's an amazing case. Super cool. How did the patient do?
This patient did really well. Unfortunately, she only lived for about 6 or 8 months after. She ended up with a progressive disease within her lungs as well. But she was one of those cases where she was essentially non-ambulatory, and that was her biggest complaint. She was ambulatory after this. Her pain significantly decreased. She wasn't pain-free, but I kind of lump these patients into two different pots, right? There's patients that you can fix their function, and they all of a sudden, they weren't ambulating, they're ambulating now. But they'll tell you, they're still having a decent amount of pain, but you've taken them from just sitting on the couch all day to being able to be independent, right? And then you have the other patients where you've really fixed both pain and function, right? And so, those are the home runs. I wish those happened all the time, but the vast majority of these people get better. There is some times where we're going to do this prophylactically. They've got a big lytic defect and you're worried about, an impending pathologic fracture, but they're not super painful, right? Like, let's just say they had, a big lytic defect treated with radiation, good tumor response, but then you have this like kind of poor quality bone, not really healing. And you're worried about this patient who could live for a long time now having a protrusio and then having to go on to the Harrington, right? So those patients are going to be sore. They're going to know we were there. But prophylactic fixation also has, it's a big component of this as well.
So what do you tell these patients for, the patients that do have pain? What do you articulate to them in your pre-op visit about pain reduction or pain improvement?
Yeah, so my kind of blanket statement to them, and I'll tell everybody this, is for the vast majority of patients that we do this to, you're going to get some pain improvement, right? Like, we don't have great data that shows all of our retrospective data, some of which was published from here. There's a lot in the European cohort. Steve Yevich has a good cohort at MD Anderson, is patients tend to get better and they tend to ambulate more, much like this prospective study we discussed from Harvard, right? I mean, that's what you're shooting for. If you can improve an ECOG status, that's like almost as valuable as improving a pain score, right? I mean,
absolutely,
because your ECOG status may now make you eligible for other therapies. I tell them generally nobody's going to leave the procedure being worse, right? Out of the peri-procedural part, if you come in for a prophylactic fixation, you're going to be sore for a week or two. You're going to know we were there. If you come in and you're 10 out of 10 pain, the pain from the procedure and the ablation is going to be less than your normal pain. You're probably going to feel better the next day. And we're going to get you up and moving around. And so it kind of goes depending on what you're actually going for, right? I mean, if it's a prophylactic fixation, it'll be a little bit different than if it's, for pain. Unless you have a nerve complication or you create a complication during the procedure, we really don't have anybody that gets worse from the procedure, right? Occasionally, we'll have somebody that may be nagged by where a screw is in the bone. The ischial screw goes straight through the hamstring ligaments there. And then the posterior to anterior screw is typically, if you're a fairly skinny patient, there's not a lot of tissue that covers that, right? So sometimes they can feel those. That's very few and far between. The complications that we've had, which are well reported in some of these, obviously most of them are with ablation, right? The sciatic nerve's nearby, the obturator nerve's nearby. You're putting K-wires near the bladder. We haven't really had any of those issues with pelvic organs. It's mainly been nerve issues that have come up after. Occasional hematomas, right? So we had pseudoaneurysms of gluteal arteries. You're putting an 8mm screw through the glute and you're indiscriminately putting it through the gluteal muscle, right? You're just following your guidance line because you got to hit that corridor. So, we've had a few pseudoaneurysms. Patients have persistent or increased pain post-op. It's usually because something happened. It's not from the construct or anything like that.
Okay,
so
got it.
Vast majority, I'll say you'll get better. Give it 2 days to 2 weeks for you really to start realizing a lot of that pain relief. Some people are a little bit longer. Some people, feel better the next day. But as a whole, it's been very beneficial for the patients that we've treated.
Yeah, great point. And all of it's about setting expectations, right? So even in my pain practice, again, I haven't incorporated pelvic fixation yet, and for a lot of my other pain interventions, I don't promise full pain resolution. As you said, improvement, right? So I think very relevant. And then I presume a lot of your patients they're just going on to weight bearing. There's very limited restrictions, unlike a large surgical intervention with these type of constructs, right?
Yeah, absolutely. So we always get them, they're going to be eval by PTOT immediately. And vast majority, again, are, weight bearing is tolerated afterwards. A lot of them came from us, went from walking to a cane and then to a walker, and then they make it to our clinic, and then we got to transition them out of that. So sometimes they may go back to their assisted device until they get strong enough to do it. But
build back up the muscle
idea
mass
is that they're able to do it. The other thing I'll say about this is, probably about 75% of our patients go home same day now.
That's amazing.
So
wow.
We've taken, and this is where I think, modern medicine and the things that we have now is you went from a Harrington procedure to, this huge operation, long hospital stay afterwards, to if we do these patients first start and we're done by 9 or 10, we observe them for 2 to 3 hours. If their pain's under control, they go home. If we do them in the second half of the day and we're finishing up about 4 or 5 p.m., we'll usually keep them overnight or give them the option to be discharged at like 7 or 8. 3 or 4 years ago, everybody was staying overnight and we were observing. And then we really realized that like patients do really well after this, right? And so no need to keep them over. And now we're kind of trying to get everybody out same day, which is crazy.
Well, that goes for everything. Most of my livers go home the same day. Most of my lungs go home the same day unless they need a chest tube, right? So absolutely, we're all pushing that boundary. I do want to make one other comment. I think there's, you talked about cohorts of people, people where you're improving function, kind of improving pain, people where you're improving pain and function. For me, over the course of my career, I've seen a few patients where it's about pain and it's not about function. And I've had patients tell me in clinic, I don't care if I can never use my arm again. I know that I'm dying. I just don't want to be in pain, and then I just go after the superior scapular lesion basically, right? So I think all three are 100% relevant. It again is having that conversation preoperatively in a clinic setting, understanding what the needs of the patient are, and then setting expectations and goals for what the outcome is going to be, right? So kudos to you, all the individuals that came before you, to your team. This is amazing, phenomenal work. So great job. And thank you for being on the show. Any last words or thoughts?
I would just encourage anybody out there, especially, the IRs, orthopedic surgery, if you're listening to this. I mean, like I said, there's a huge patient population that we can help with collaboration, with taking on these cases, and they're in every system. I think it would just behoove you to kind of look into these procedures, look into starting to pick it up. You don't have to go straight into screw fixation to do this right. Start small with MSK practices. Everybody's capable of doing it. You have the skill sets. You just haven't used it for this set of cases yet. And so I would just encourage anybody out there that wants to do this to do it. Reach out. I make myself available to people that, after we go to conferences and give talks. I'm happy to answer questions. I want to pass on everything I've learned from my mentors to anybody that I can. I'll give a shout out to Sean and Steve Yevich for all the stuff that they've done. And I can't thank them enough for teaching me what they did. And all of the things that you see now are, on the shoulders of what they did before us, right? So Sean is still pushing the limits. He's, bringing in robotics to UCSD. That's going to be the next wave of stuff. And so, the MSK space is a really awesome space to be in. And I think, in most practices, it's kind of an unmet need. And so, get out there and learn as much as you can.
Yeah, great points. Spirit of innovation, spirit of collaboration, spirit of mentorship as well, right? And, in addition to robotics, we have the tribute trial now. So a lot of exciting stuff coming. So Brandon, again, thank you. Appreciate all the time. Wonderful discussion, great cases, and amazing work. And we'll stop there.
Yeah, it was awesome, man. I appreciate you having me. It was good hanging out.
Yeah, likewise, man.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.